Ryan Stanton here with ACEP Frontline, joined today by Dr. Kathryn Hawk, somebody we've had on the program in the past, and somebody that's helped multiple occasions discussing the opioid epidemic, medication-assisted treatment. Today we're actually going to talk about overdoses themselves, so kind of getting back to the basics, but some research and some things that she is looking into. Dr. Hawk is a physician through Yale Medicine, and let's just dive right into it. So Dr. Hawk, thanks for returning with us with the Frontline.
Thanks so much for having me.
So tell us a little bit about overdoses and where we are in the work that you're doing.
Sure. So as you know, over the past several years, we've continued to see a rise of drug-related overdoses, and specifically opioid-related overdoses. And that's something that we've seen in our emergency departments sort of every day. One of the things that, as someone who spends a lot of time thinking about how we can link people to treatment and how we can think about how to keep people as healthy as we can help them, one of the things I was specifically interested in is what we can do sort of in the ED space with patients that we see following a non-fatal opioid overdose. Specifically was interested in if there are strategies that we can use to make engagement more likely, whether in harm reduction services or linkage to treatment, and was very interested in specifically sort of what people thought they needed.
So with that in mind, I mean, I think most of us have experienced the opioid-based overdose. The patient who gets the Narcan comes in nauseated, agitated, a little sweaty, all that sort of thing. What are some of the things that you uncovered with regard to, or things that you found out with regard to the overdoses and the patient perspective?
First off, the thing that kind of came out in my clinical practice, and this is not rocket science, but I think sort of one of the most fundamental things about taking care of people after overdose is a sense of compassion and approaching them with sort of a non-judgmental approach. One of the things that we've heard from talking to individuals and from patients is they feel stigmatized in the emergency department. They feel like people are judging them. They're often very embarrassed about sort of what has recently happened, about having an overdose. And so just even approaching people, right out of the gate with, I'm sorry that this happened today. I would like to help you. I understand that you're uncomfortable. How can we work together to keep you safe today and keep you here? And, what can I do to make you more comfortable right now? In our ED, we have turkey sandwiches. In other EDs, it's different things. But even just that sort of basic human kindness, I think, is one of the most important things for connecting with people, particularly this patient population.
I think I need to make a correction. Every emergency department has the turkey sandwich.
Okay.
That is the only universal aspect of emergency medicine is that turkey sandwich. The white bread, dry turkey.
Yes, mayonnaise on the side.
Yes, mayonnaise on the side box. That is universal emergency medicine. And actually, I was wondering about getting that should be something that's sponsored or potentially look into, because it is the only thing that's across the board, every place across the United States. I need my turkey sandwich. So with that in mind, what are some of the things that our physicians, our APPs, need to think about with regard? You mentioned some of these thoughts that, this situation for the patients sucks, and we understand a lot of that, and demonstrating some compassion, understanding, some empathy. What are some of the things from the tips from our standpoint of approaching this sort of thing? Because it can be very frustrating from the physician APP standpoint. It's like, oh, another overdose or something else, and agitated and folks that are very uncomfortable and wanting to get out of the emergency department. It's just one more thing on top, and that's getting into some of the stigma standpoints, but some things that the physicians and APPs can keep in mind as they walk into the room of somebody who has just been revived from an opioid overdose.
As I mentioned, I had all kinds of ideas about what I thought people need. I thought people needed naloxone. I thought people needed a referral to treatment, to start buprenorphine and refer to treatment if that's something they were willing to do. But it occurred to me that we didn't actually have a lot of knowledge about what patients really wanted. And so I applied about a year and a half ago to the Emergency Medicine Foundation for a pilot grant to do qualitative interviews with people in the ED after overdose, to really get a sense of, what it is that, what are their perceived needs and what do they think is important. And so the sort of overview of the research is, so I did qualitative interviews with 24 people in the emergency department following an opioid overdose. This was sort of in the hour while they're kind of in the ED waiting for disposition, and there were short interviews, maybe 15 minutes, and had an interview guide, and we focused really on 5 domains. One was sort of around overdose knowledge, one was around sort of prior treatment experiences, goals, and sort of proceed what they thought the right role for the emergency department was. And so some of the things that I found were not necessarily surprising, in the sense that many of the patients that I saw had, about half the people I enrolled had sort of one of those risk factors that we think about when we think about a risk factor for overdose. They had either used alcohol with a benzodiazepine or other sedative, had recently been released from an abstinence-based inpatient treatment facility or jail or incarceration. Those were sort of the main overdose risk factors that we saw with this patient population. But when we ask people, what it is that is most important to you and what do you think that you need, several people that talked about needing a job. I need a place to live. I can't really think about engaging in treatment if I'm living in a place where there's active ongoing drug use, and I don't want to be homeless, and so I'm going to stay in this house with my family with active ongoing drug use. And so one of the things that really sort of shaped for me was kind of thinking about Maslow's hierarchy of need. I think that when I'm talking to people about starting medication for treatment or starting buprenorphine, I think that's a little bit higher up in the triangle than the very basic need of like food, water, shelter, safety. And so, not that treatment isn't related to meeting those needs, but one of the things that I definitely learned was that, when we talk to people, if I'm coming at them from, you should do treatment because it, will help with illicit drug use, it'll help with, reduced HIV transmission and hepatitis C transmission. There are all kinds of, large-scale benefits. But for the individual, the thing that they care most about that day, for many of the people I talked to, was, very basic fundamental needs.
And that gets to a lot of some of the things we don't think about, and really a lot of times why we have return visits, utilization in the emergency department, is understanding that many of the needs are more than science. I mean, listening to you talk, a lot of it was your thoughts are science-based. This is what you need: recovery, future safety from overdose, things like that. But to the patient, there's looking at those other confounders, because opioid overdose abuse, really any abuse, doesn't exist in isolation. And there's a lot of things that go into it. And just as a patient I had last week had been sober for quite some time, but re-entered that environment where there was a lot of abuse and risk, and ended up having an overdose. So understanding those types of things can be huge. And so, you mentioned short interview, but 15 minutes. But for us, for most ER docs, 15 minutes is still relatively an eternity. So what are your recommendation? And I know you're still kind of working through a lot of this data and information and how you're going to write things up. What are your recommendations in terms of things that the emergency physician needs to really inquire about, kind of that hard-hitting, hot item that we can check into or ask about or kind of engage in order to improve that success at preventing overdose and encouraging recovery?
So other things that came out of the data was many of the patients actually did have a fairly good working knowledge of overdose prevention strategies, but some did not. And so there certainly were opportunities to deliver overdose prevention education. People expressed sort of a great gratitude for the existence of naloxone and thought that, the ED was certainly an appropriate place to discuss giving out naloxone. Many of the patients we talked to talked about the fact that, if you're not ready, we're not going to, the ED is not going to get them sort of ready, but that it is a really important point that when people are ready, to make it really, really, really easy to get linked into treatment. And so that's, one of the things that, as we've spent a lot of time doing is trying to figure out how, in our ED and sort of other EDs across the country, how when we see people at sort of this vulnerable point who are ready to, either start treatment or try to engage in healthier behaviors, whether it's getting, plugged into harm reduction services or other things, just trying to make sure that we are able to have these conversations with patients in a non-judgmental, patient-centered way, and that we're able to sort of provide resources around how to keep people healthy. And if they are ready and willing to start medication, we have lots of evidence around buprenorphine improving outcomes for patients. We have, as Dr. D'Onofrio's study, we have data from the emergency department that it greatly enhances the likelihood that someone will be engaged in treatment at 30 days. And if people are ready for treatment, we know that treatment works.
Well, as physicians and other staff in the emergency department, being judgmental or coming at them in a judgmental, aggressive manner is not going to be helpful. You know, these folks have almost died today. So you coming in there and driving that point home is not going to change that. It just potentially alienate that patient to the point that return to that situation. I mean, that's honestly one of the recurring themes of addiction and overdose is that isolation back to that environment and getting almost pushed back to that environment by those around it instead of being somebody who tries to understand. One of my favorite things that I've always done is sat down with my overdose patients or addiction patients. It doesn't even have to be overdose, but you know, even abscesses, things like that, and just talk with them about how they got to where they are, and then kind of, you know, sit down and just chat about where the next steps are going to be and how to get to that point of recovery and sobriety.
So that was actually one of the things that I haven't figured out if I'm going to write about this, but I certainly felt it was a really interesting experience in the sense that doing these interviews, I mean, people were just so grateful to have an opportunity to talk about their story, you know, in a way that, you know, I did not expect for people to be so, you know, willing to share their experiences and talk about the fact that they felt really sort of alienated and judged in the past, and just the opportunity of, you know, tell me how you got here today is something that people really felt empowered in their ability to share their story.
And that's one of the simple things we can do because addiction naturally is that isolation and kind of builds on itself over time. That addiction, the rewiring, and all that stuff just kind of builds on itself to isolate the person, to kind of pull them back in. I mean, if you've read a lot of the books, whether it's Dreamland, whether it's No Easy Day, whether it's whatever books that may be out there, just understanding that really one of the powers of addiction is pulling people into that isolation, which makes them feel like that's kind of the only option. And we may have that. And there's a lot of research out there, whether it's with alcohol or drugs or whatever it may be in that emergency department. We have that ability to do that quick intervention and do that quick discussion, engaging the patient that may change the course of their life forever in terms of giving them that little grain of hope that they need to kind of take that next step. And one of the conversations that we had is that emergency medicine was kind of this weird landing spot for a lot of addiction and overdose related issues, but really it's becoming that kind of the understanding that it's really the doorway to a lot of opportunity because a lot of that acute situational issues end up in that emergency department. And I know you've done a ton with the bridge clinics and the bridging and the medication-assisted treatment and the initiation of recovery in the emergency department. Where do you see that role of emergency medicine in terms of the solution to where we are right now with the opioid epidemic?
One of the things that has just been so rewarding is to see, you know, over the last couple of years, to see emergency physicians really embrace the fact that we have an opportunity to help improve people's lives in this way. And so I think the biggest sort of hurdles initially were around professional identity and what people thought their job was, you know, and I think seeing so many young people in their emergency departments with, you know, with overdoses, even with, you know, this sort of there's a new manuscript that came out a couple of weeks ago, Scott Weiner out of Boston, essentially, you know, that shows that essentially it's a 5% 1-year mortality rate. If you're seen in an emergency department with a non-fatal overdose, this is using a linked data set out of Massachusetts, your 1-year mortality is 5%, and it's 1% in 30 days. And so when you look at that compared to other medical conditions we treat in the emergency department, there was a really nice thing on Twitter that actually Kit Delgado out of Penn did, but, you know, overlaid, you know, this large data set in Southern California on basically heart scores and sort of 30-day outcomes and heart scores mortality versus, you know, non-fatal overdose. And I think it was the low risk heart score 30-day mortality, you know, either acute MI or death at 30 days was, I think, 0.09 versus 1%. I mean, it's really staggering when we think about our ability to affect outcomes.
Well, I mean, just kind of drive the point home that 1 in 20 of those people that you see in front of you are going to be dead by that same time next year is huge. And you may have that opportunity in the emergency department at that point to kind of change that course and divert that course just with a little bit of time and putting in programs for initiation of management and treatment and recovery and then referrals to the appropriate setting to keep that going. Any other messages that you may have for the folks out there, and once they see the next shift when they come in and they have that overdose come into the emergency department, that patient is sitting there that young man or woman sitting in front of them in that uncomfortable situation of acute withdrawal and wondering how the hell things happened the way they did, how they got to where they are, and now they're sitting in front of you.
Well, I'd like to put in a plug. So ACEP, the Equal Network, they have an opioid initiative that is a structured QI project and learning collaborative for sort of medical departments or medical directors and emergency departments to participate in. It also has this huge sort of trove of resources around how to take care of patients with opioid use disorder and around prescribing. And so sort of everything that you could need around thinking about how to start a program for ED-initiated buprenorphine, overdose prevention. There's a link to the state of New York City actually just put out this really amazing sort of resource around providing care for patients after opioid overdose. There are lots and lots of resources on this website, and you can certainly go to it during a shift. I would encourage you to sort of peruse the website when you have some downtime, not necessarily when you're taking care of a patient that second, although there are resources that can guide you sort of through how to do that. But there are resources available. You don't have to reinvent the wheel if you're trying to get a program up and running. If you're looking for tools for how to engage patients, we have on the Yale ED buprenorphine website, we have sort of tips and tricks around motivational interviewing to enhance patients' motivation to either engage in treatment or engage in overdose prevention practices. And so there are resources out there and available, and I encourage folks to check those out.
Yeah, I do love the Equal site. It's been steadily building over the last few years and continues to add to that. And it's to the size now that it probably needs to be. We probably need a little bit of design stuff to help make it easier, because there's so much data now and so much information, so much education on that site. But it is a great place to go and kind of get through the nuts and bolts of where folks have gone, the great ideas people have in terms of pain management, evidence-based pain management, addiction prevention, and then as well as what you're really focused on is that recovery, that intervention recovery standpoint through the emergency department. So some great resources there. Actually, I have turned, being charged with state of Kentucky, just basically turned over the Equal site and said, here you go, here's everything else. So thanks for that work and everything you guys have done, because it made it easy for us to not reinvent the wheel when it comes to all these resources and things and education that we have. How can folks get in touch with you? Do they have any more questions, thoughts, or interest in the opioid and recovery aspect?
Sure. So email is easy. It's just my name. So it's Kathryn.Hawk@Yale.edu. I am also on Twitter at Kathryn_Hawk. Although I'm still understanding the Twitter universe, I'm better than I was last time we talked. So those are really the best ways to reach me.
Now, it is easy unless you try to spell Kathryn the traditional Kathryn way. It's KATHRYN.Hawk, HAWK at Yale.edu. And actually pretty easy to find if you Google her online with opioid recovery, Yale. She comes up pretty easily. And you can even do the old-fashioned fax the clinic kind of thing. I've always found that interesting. Yale loves to put the clinic fax machine as part of your contact information.
I have neither a clinic or a fax machine. So I have
well, you've got one on their website.
I have no idea where that goes.
We should try it out. Somebody fax Kathryn's clinic, 203-785-4580. And we'll see where that ends up. So that way Dr. Hawk can know where her fax machine is. As for me, you can contact me, youreverydaymedicine@gmail.com, youreverydaymedicine@gmail.com. I do not have a fax machine, but I do have Facebook with ACEP Frontline and @everydaymed on Twitter. And until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.